Hi everyone, this is Neel Raithatha, consultant audiologist and director of earwax. Thank you for joining me in my latest video using the iClearScope endoscope. And this is of the left ear of the patient featured in my last video. I think that's number 1584. And this was the worst ear out of the two. So just to recap on this patient's case history, they've been suffering from bilateral severely impacted earwax, or in this case dead skin, for a couple of weeks. I'm actually, as I'm narrating, just getting the patient's notes just to remind myself. Yes, and they were seen by another specialist locally on two separate occasions. The last one was last Friday, and bless them, they did try their best. They spent a long time trying to remove this, but the specialist just recommended the patient visit myself because they've already visited twice, and they weren't able to hear at all from this ear. So this is their worst ear out of the two. And what you can see here initially is a plug of wax, dead skin. It's matted, it's really dry. This patient's got a lot of terminal hairs. So the terminal hairs are the thicker hairs that protrude outwards, and we all have them in the outer third of the ear canal, the cartilaginous portion. The other type of hairs that are lining our skin are called vellus hairs, if memory serves me correct. So they're like peach hairs, the hairs on a peach. So they're really soft and almost invisible. It did make it slightly, I managed, but I'm assuming from a viewing perspective, some of you may not like it. Now, because there's a lot of dead skin here, it's quite reflective because the hairs are there as well. But as we remove this, you'll get a non-reflective view, hopefully. And it was a difficult case. Now, they have been using drops for the last couple of weeks. It may not appear like it because it just looks bone dry in there. But I've just put some drops in myself to lubricate this. And so initially I'm just using microsuction, but the tool that helped me remove this was the right angled correct. So in yesterday's video of their right ear, it was actually the right angled ear pick, but on this occasion it was the right angled correct. But unlike their right ear, in this ear, once I removed this plug, there's a lot more dead skin debris that I had to remove, and there was also a small ulceration on the floor of their ear canal. So we call that the inferior aspect of the ear canal, and it was positioned on the osseous portion, so on the bony part of the ear, in the pars media region. So you can subdivide your ear canal in thirds. You can do it in different ways. So the outer third is made up of cartilage and the inner 2/3 is made up of bone, but you can further elaborate on that and you can give distinct names to these different thirds. So the outer third you can also call the pars externa region, the midsection of the ear canal, pars media, and the latter third, pars interna. So they had an erosion, and it would appear like an ulceration in the pars media region, so the midsection of the ear canal on the floor of the ear canal, so the inferior aspect. So I have written to this patient's GP and have recommended an ENT referral because of the ulceration and because obviously there's some erosion of bone there, and it's to rule out a possible rare external auditory canal cholesteatoma. There was no visible discharge there, but it's best having this patient getting examined by ENT. So you can see how strongly adhered this is. I'm trying to release it from the posterior ear canal wall, but it's strongly adhered because of all the skin adhesion. So I'm now going in with the right angle correct, and you can probably see the curvature on that correct. Hopefully it's visible. So there's a slight curve of the correct, and the way I've inserted it is that the curve mirrors and mimics the curvature of the posterior canal wall. And it just enables me to glide a lot better. And also the tip of the correct is thinner, so it's tapered compared to the main spoon, if you like, there. So the tip of the correct, the furthest away, is thinner than the bit that connects to the handle. And again, that tapered tip really allows me to get in between wax and correct. And although it's tapered somewhat, we use extremely strong material to manufacture this, so it's still extremely strong and robust. So I've managed to separate some of the keratin plug from the canal wall using the correct, but I then went in with the forceps because there's a bit of skin that was protruding outwards, and sometimes you can grasp onto that. But I've just gone back in with the correct again, and I went more superiorly. So again, I've angled the correct in such a way where the curvature of the correct mimics the curvature of the roof of the ear canal. And this is testament to how strong the right correct is, despite its slim profile. I've managed to extract that. So going back in, and the ear was, I mean, the patient could hear significantly better at this stage, but you can see there's a lot of dead skin here. So we're going to spend the next 10 minutes or so peeling all this away. So I'm just using microsuction at this stage. I'm trying to get underneath the skin. Now, whilst you watch this, I just had a really interesting day. So I had a patient who previously visited me back in December 2020. Again, I've just got their notes up. And they had bilateral earwax, and it was pretty much straightforward procedure. And it's been almost 5 years since they last attended. So they were experiencing symptoms again. And I mean, the patient admitted it to me when they attended, but because the procedure was so straightforward the last time, that they went somewhere else because, I'm a lot more expensive. So they thought, they'll go somewhere else a bit cheaper, a bit closer to them as well, which is fine. I can understand that. But the patient went there under the pretense that because when they attended to see myself, it was so straightforward that, kind of almost anyone can do it. So they visited a clinic just yesterday, not far from myself, and I'm going to do a bit more research about them because I've not really heard of them. So it might be a pop-up clinic. You're getting many of these at the moment. The patient's unsure of their qualifications, but anyway, the patient did advise that whoever they saw was really, really pleasant and nice, but he could sense they were struggling with the wax removal, and they advised that the person that the patient saw said that they've removed the wax. It's just a little bit left, and it was non-significant, and they can see the eardrum, and all the rest of the little bit of wax in the ear will naturally migrate, which is fine. I mean, earwax is meant to be in the ear, so as long as the patient's symptoms are alleviated, a bit of non-significant wax here or there, which is difficult to remove in particular, is probably best left alone if a specialist is not confident removing it. But the patient just wasn't convinced because they actually felt the hearing got worse after the procedure. So, and obviously the patient parted money, paid for this treatment, and they booked in this morning and asked if we can see them as emergency. We managed to squeeze them in, and lo and behold, both ears were fully occluded and impacted with wax. It was smothered all over the eardrum, and our suction pump is positioned just behind where the patient sits. So it's relatively noisy, I would say about 75 decibels, and the patient wasn't able to hear that at all upon a training. In fact, they weren't able to hear any conversation with myself. And within I wouldn't say a few minutes, but it took about 10 minutes, I think, in both ears. And I've got so many good videos to upload, so I'm not sure when I'll upload that, but I will make reference to, obviously, the case history so you guys can watch it. And the patient obviously just felt like that it was daylight robbery. I mean, if they had been told that they weren't able to remove all the wax and to potentially come back or recommend them to go somewhere else to remove the rest of the wax, the patient would have accepted that, but they were told that the wax had been removed, there's only a little bit left that was non-significant. So the patient got really worried that they thought something else was going on with their ears, hence why they asked for an emergency appointment, because it was quite frightening for them, because they, as I mentioned, they also actually felt their hearing was worse after the procedure. So I think the patient's going to go back, show the video of their ears and ask for a refund, which I think it should be provided, if that, of course, is how the appointment went. So obviously I just don't want to believe the patient. I've got no reason to doubt them, but obviously the specialist that they saw may have a different account of the appointment. I'm probably being a bit too nice to that other specialist. I'm sure the patient wouldn't make up story, but you never know. And interestingly, also in their right side, they had an erosion of the floor of the ear canal. Now, there was no underlying exposed bone. The skin had healed over, and taking the case history, this patient very likely got benign osteonecrosis, which is death of bone, the degrading of bone, necrosis of the bone. Typically occurs in the ear, at the floor of the ear canal. In patients with reduced blood flow to the ear, so they've got low or even high blood pressure, or if they've had radiotherapy in the ear, for example. There's particular medications patients are prescribed for osteoporosis, bisphosphonates. And what bisphosphonates do, they stop osteoclasts, which are specialized bone cells that live on the surface of the bone. And what osteoclasts do, they basically break down the surface of the bone into its core minerals and tissues, and it redistributes that via the bloodstream to other parts of the body where new bone can be formed via osteoblasts. So bisphosphonates, they halt the function of the osteoclasts, which inadvertently can make the surface of the bone more brittle, because there's bacteria, potentially fungus or viruses that can also penetrate the surface of the bone. And this recycling of bone is actually quite important to the overall health of bone, because if you've got some harmful bacteria on the surface of the bone, the osteoclasts inadvertently remove that by breaking down the surface of the bone, and then new bone can be formed to replace that damaged bone. But with bisphosphonates, the activity of osteoclasts are inhibited. So in the case of the ear, that could cause the surface of the bone become brittle, and it can decay, and you get a ditch. Now, whenever you've got an erosion in the ear canal, when it's localized like this, you just got to be careful of a potential external auditory canal cholesteatoma. So in this case, I have referred the patient. The other patient we kind of knew about, but the other specialists wouldn't have known about it. And that's the point I was trying to make, because they, number one, didn't fully clear the ear, and just say it was an external auditory canal cholesteatoma. They would need, kind of urgent treatment for that, or assessment, should I say. So you can see the eardrum there. Now there's still a bit of skin, and there's a blanket of skin just there, and we're going to remove that in a moment. So whenever I see things like this, I think, if it was soft wax, I'm less concerned, but I can see there's some dead keratin, and now that I'm just cleaning out this kind of little erosion, you can see the erosion there. It's very hard to see if there's kind of any exposed bone, but I think there is just some laterally to the erosion. So again, just want to get this examined by ENT. It's just more skin. Now, we don't get every little last speck. It's not possible. What you see on screen is really, really magnified. The ear canal is extremely narrow and small. So there's limitations of what you can do. But we're going to remove as much as possible. And that leads on kind of to another case I have today. It's of a colleague of mine. When I first started working, when I qualified, I initially worked for the National Health Service, but I think in 2012, I decided to work for a private company with the intention of just learning how it works, the industry, the private industry, before opening up my own practice. And there was a really nice rep, a hearing aid area rep, that would come visit me, and at the time I was working for a national company. I've met him there, but then when I first opened my own business, I didn't have a physical premises, so my registered address was my home address, and I was working like domiciliary visits, visiting people at their homes, and also working from different GP practices. So whenever I had a meeting with one of the reps, I'd invite them to my home address, which is the registered address, and again, I'm probably diverging here, but he brought it up, so I'll just remember, and I couldn't remember it until he did bring it up, but it's been years since I've seen him, and he reminded me that when he came to visit me, that I had made some curry the day before, and I packed some for him, because he loved curries, and he was just telling me how much he enjoyed it. So it was nice seeing him, but it's always strange when you have patients who you know personally, either a friend or family member, it's always a complex case. It's never straightforward. And he had a really, really complex case. And again, I will upload that in due course. But to summarise, he's been suffering from an ear infection in both ears for the last fortnight. And he's seen a couple of local specialists, and the infection's still persistent. And it was their left ear, they couldn't hear at all. The right ear, they had 50% hearing. The left ear was acute otitis externa. It was so swollen and inflamed. And when I was putting my suction probe in, even the small suction tip, I was getting collapsing of the ear canal. When you've got a lot of edema, swellings, a lot of fluid in the cells, when you perform microsuction, all those fluid in the cells in the ear canal, it gets attracted by the suction, which causes the canal to collapse. So, I could barely even get the small suction tip in, but I did manage to get majority of some discharge and dead skin off the eardrum. And the right ear, again, they have psoriasis, and it was a really, really narrow ear canal. It was quite hairy at the entrance, and they had this crusted skin all over the ear canal and eardrum. And although it wasn't swollen, the ear was really, really narrow. And but fortunately, I managed to peel away all that skin and to reveal the eardrum. It looked like a brand new ear canal. So I will upload that in the next few days. I also had another interesting case, and I'll just finish off because the video's coming to an end. But so of a patient who had a hearing test at work. So they work in a noisy environment. They normally have it every year. And the person who performed it's a non-audiologist. They said they failed that hearing test and they've got bilateral impacted earwax. But they came here, they didn't have any earwax. I performed a hearing test absolutely fine, and the patient was obviously furious because it's now on their work record and they're worried about their job. But I reassured them that I would send a report. It was just another day in clinic. Well, I hope you enjoyed that video, guys. Sorry for diverging. Sometimes, as you know, I like to giving these stories. Take care, keep well, speak soon. Bye.